Shall I start?
Yes, please.
Okay, so good morning all the
Set the timer, please. Yeah.
Good morning all the judges, chairpersons and all the other presenters and speakers. I am Dr. Vishwendra Sisodia, and on behalf of VST Center for Glaucoma Care, Shantilal Shangvi Cornea Institute and LV Prasad Eye Institute, Hyderabad, I would be presenting the first paper. The title is Comparison of iCare IC200 and Goldmann Applanation Tonometer for Intraocular Pressure Measurement in Post-Keratoplasty Eyes. These are the abbreviations which I would be using along my presentation. Post-PK glaucoma, as we know, is one of the common causes of graft failure and loss of vision in eyes which have undergone keratoplasty, and it is critical to estimate and pick up intraocular pressure elevation in the early post-operative period. Now, there are various challenges in measuring intraocular pressure in these eyes because of the presence of thick and edematous graft, presence of astigmatism because of sutures, and presence of bandage contact lens in the early post-operative period. Now, before coming to the purpose of this study, why we plan to start the study is because we used to see a lot of patients being referred from the cornea clinic post 3 months or 6 months or even 9 months of transplantation who used to have advanced disc damage. And when we go back to the records, we used to see that the pressure was checked with iCare over BCL, without BCL. So that's why we did this study to compare the IOP measurement obtained using iCare IC200 and GAT in post-keratoplasty eyes and assess the IOP with and without presence of bandage contact lens. So it was a prospective cross-sectional study conducted between June 22 to May 23. We included eyes with minimum 4 weeks post-keratoplasty, absence of ocular pathology other than glaucoma. The indications for keratoplasty were keratoconus, corneal opacity, dystrophies, bullous keratopathy, previous graft failure. Both clear and edematous grafts were included with and without BCL. We excluded eyes with active ocular infection, central scarring or bullae which can preclude GAT IOP estimation, and eyes with previous VR surgery. We also included the normal controls. So we included, as you can see here, eyes with DALC, with DMEC, with DSEC and post-penetrating keratoplasty. And as you can see in these OCT images, there is presence of BCL over all these grafted eyes, and if you can see, there is a presence of tear film between the BCL and the graft, which could also give fallacious reading of intraocular pressure. So we used iCare IC200 and Goldmann Applanation Tonometer, and the bandage contact lens which we use is the silicone hydrogel contact lens. So first the IOP was measured with iCare over the BCL by the first examiner, then the BCL was removed and again the IOP reading was taken with iCare. 5 minutes later another examiner measured the IOP with GAT without BCL. So there were total 52 control eyes, 59 eyes which underwent full thickness keratoplasty, 44 eyes which underwent DMEC or DSEC, and 33 eyes which underwent DALC. So as you can see here in this bar diagram, in the control eyes in which the IOP was checked with iCare with BCL and without BCL had an overestimation of IOP as compared to GAT. These are the normal control eyes. Whereas PK eyes had underestimation of IOP with iCare both with BCL and without BCL, and similarly underestimation of IOP was seen in EK and DALC eyes as well. These are the Bland-Altman plot analysis of the control eyes, of the PK eyes, of the endothelial keratoplasty eyes and the DALC eyes. So if you can see the difference between the iCare with BCL versus GAT in the control eyes, there was overestimation of IOP, whereas if you can see the difference between iCare versus GAT in penetrating keratoplasty, endothelial keratoplasty or DALC eyes, there was underestimation of IOP. Now you would say that statistically significant difference is not there, but here rather than talking about the p-value, the relevance is more of clinical significance. If you take any case-to-case basis and analyze these patients, it is very important to rule out glaucoma, that the glaucoma should not be missed, and these patients should be promptly treated and in adequate time as well. So my take clinic message is that the iCare IC200 tends to underestimate the intraocular pressure in post-keratoplasty eyes, whether full thickness or lamellar. It can lead to underdiagnosis and suboptimal management of glaucoma in these patients. Therefore, careful consideration should be done while choosing tonometry methods in these patients. Thank you.
Hello. Can you tell me one thing regarding applanation tonometer? In case of keratoplasty, there will be a lot of astigmatism. How did you go about in these cases?
Sorry, I didn't get your question.
In ketoplastic cases, the sutures are already on. Even if it's not the on, there'll be a huge astigmatism.
Yes, yes.
So how did you go about taking IOP in these cases with Goldman ablation tonometer?
So as per if in high astigmatism patients, the guidelines which are there to do applanation tonometry that were followed, which are given in
And
Whitaker's.
which guideline? That's what I want, because you've not mentioned here.
Okay, so according to the Whitaker's article, there are 3 ways which you can measure.
I'm not asking okay, how many ways are there. I'm just asking what method did you apply, because you have not mentioned in your article.
So first the IOP is checked in the horizontal axis, then the applanation prism is rotated.
I'm not asking is checked. I'm saying what did you use, which method did you apply?
So this method we use. First we measured the IOP with the prism at the horizontal axis, then we rotated the prism, and then we measured the IOP at the vertical axis, and then the average of these IOP were recorded.
Yeah, just one question. You are taking Goldman as the standard in such cases.
Yes.
And Goldman can be fallacious in such cases also.
Yes, yes.
So,
Exactly.
so what made you think that under the reading that was, that was lower in eye care was wrong and Goldman was right?
So what we have seen in our patients and also clinically, that though Goldman might not give the accurate estimation of IOP in patients with any form of keratoplasty, but still the IOP measured with GAT is much more reliable as compared to eye care.
Which method would be the ideal in such cases?
So I would say that if there is no epithelial defect, I would still go for Goldman applanation tonometer over eye care or over any other form of tonometry.
Thank you.
All right, thank you. Next, I'd like to invite Dr. Abhyuday Saxena for his presentation.
Okay, thank you, everyone.
Yes, Abhyuday, you may proceed.
Good morning, everyone.
Keep the timer for 5 minutes, please.
The title of our study was the comparative evaluation of AIOS parameters in patients of angle closure disease versus normals. There is a wide variation in the reported prevalence of PSEG in India due to a lack of gonioscopic evaluation. Quantitative imaging modalities such as UBM and AIOS provide an objective method of evaluating the anterior chamber angle, which can help in the early diagnosis and timely treatment of glaucoma. Our study aimed to evaluate the anterior segment anatomical parameters quantitatively in angle closure disease spectrum using AIOS. Our objectives were to compare the AIOS findings in angle closure disease spectrum with normals, to assess any quantitative differences in the different stages of angle closure disease, and to study their possible correlation with the gonioscopy findings. It was a tertiary care hospital-based cross-sectional comparative study over the course of 1 year, and the patients included were either diagnosed as PACS, PAC, or PACG, aged more than 40 years, and patients with gonioscopically open angles and relatively small refractive errors with no other ocular abnormalities were taken as controls. The major exclusion criteria were any previous glaucoma procedures like a peripheral iridectomy, previous ocular surgeries, or other ocular abnormalities. Patients were recruited from the glaucoma and general ophthalmology services after an informed consent. Comprehensive systemic, ophthalmic, and glaucoma workup was done. Patients were classified as PACS, PAC, and PACG using the European Glaucoma Society guidelines, and age-matched patients with open angles were taken as controls. Both eyes were included if eligible. Ocular imaging was done using the angle-to-angle scan mode and the chamber view image of Cirrus HD-OCT via single technician masked to the clinical and gonioscopic data. The angle opening distance 500 and 750 microns, trabecular iris space area 500 and 750 microns, trabecular iris angle 500, and lens vault were measured. Poor quality images such as those with indeterminate scleral spurs were excluded. A total of 204 eyes were included according to the sample size, 46 eyes each in the PACS and PAC group, 45 in PSEG, and 67 in the normal group. There was no statistically significant difference in the age or gender distribution between the groups, other than a higher prevalence of females in the PSEG group. Coming to the gonioscopy findings, significant difference was observed between all the groups except between the PSC and PSEG group. This slide shows the AIOS findings of patients in different groups, and as we can clearly see, the angle gets progressively narrower in the advancing stages of angle closure disease. The measured AIOS angle parameters, angle opening distance measured 500 and 750 microns from the scleral spur, showed a significant difference between all groups except the PSCS and PSC group, with the least value in the PSEG group. A similar trend was observed for the trabecular iris space area 500 and 750, with the least value again in the PSEG group. The trabecular iris angle 500 microns from the scleral spur showed a significant difference in all groups other than the PSCS and PSC group, with the least value in PSEG. The lens vault was also measured using AIOS, and a significant difference was found between all groups, with a progressive increase in the mean value in the advancing stages of the disease. Coming to the correlation matrix of the various AIOS parameters and the gonioscopic angle grading, the Pearson correlation coefficients obtained suggested a high degree of correlation between the two parameters. So to conclude, the AIOS parameters show a statistically significant difference in the angle closure disease spectrum patients compared to age-matched normals, as well as across different stages of angle closure disease, except between the PSCS and PSC. The lens vault was highest in the PSEG group, emphasizing the role of lens thickness in angle crowding. AIOS parameters strongly correlated with the gonioscopic angle grading, reinforcing its reliability in assessing angle width. The Van Herrick's grading also was found to be a useful screening tool to differentiate angle closure from open angles. So while gonioscopy remains the gold standard, advancements in anterior chamber imaging offer an objective and reproducible approach to diagnose angle closure, and future developments such as deep learning algorithms with automated imaging analysis could further enhance diagnostic accuracy. Thank you.
Thank you, Dr. Abhyuday. So was this being done at a specific lighting condition where you were testing this, or was that variable as well?
Yeah, it was done in a semi-dim lit room.
All right. And the reliability indices for all of these were kept at high, right?
Yeah.
Okay. So this is otherwise it's a good finding to have, though as you said, gonioscopy continues to remain the gold standard.
The question is, what was the basic purpose of comparison of UST angle changes in the primary angle closure disease? What is the basic purpose? Because PSCS you said is not significant. So my main thing is the PSC suspect cases that you have to see whether it goes into angle closure or not. That you have said is still open.
Sir, we found a significant difference between the open angles versus the angle closure spectrum, including PSCS. So it can help in diagnosing the patients who are missed on gonioscopy. But as we found in the study, no significant difference was found between the PSCS and PSC group. And so
your main aim was to diagnose between POAG and PACG.
Yes, sir. Open angles versus any angle closure suspects, which are usually missed.
Okay. Next, can I invite Dr. Sushma Tejwani for a presentation, please? After that, it's Dr. Navdeep Kaur. You can get ready when the questions are being asked to the speaker on the other podium.
Yeah, a very good morning, respected judges and dear friends. My topic is interleukin 18, a therapeutic target for primary glaucoma. As we all know that most of the glaucoma treatment is on IOP lowering, and we know there are failures. So we need to look at other factors that are responsible for RGC cell death and trabecular meshwork closure that can be monitored and modified so that they can help in treatment. Now, why IL-18 here? Well, IL-18 is a pro-inflammatory cytokine which is known to be involved in neuroinflammation and activation of immune cells in the brain, and is known to be elevated in Alzheimer's, multiple sclerosis, etc. And secondly, it also has its role in tissue fibrosis and is known to have its role in pulmonary, cardiac, and liver fibrosis. So we will be looking at trabecular meshwork fibrosis. Now, how do we monitor it in glaucoma? So the aim of our study was to determine the status of IL-18 in aqueous humor of primary glaucoma patients and study its causative role. Also in reference to its severity, progression, and response to IOP lowering treatments, and also to validate the tests in vitro. So what did we do? We collected aqueous humor of cataract patients, 77 controls, and primary glaucoma patients, 137, and did ELISA. We excluded other secondary glaucomas, and also we did in vitro studies. Well, our cohort was glaucoma, which was divided into severe and non-severe based on VFI. These patients were followed up for 1 year and followed as stable and progressors based on VFI drop per year. Then we also looked at patients who were not responding to the glaucoma medications, and also after trabeculectomy after 1 year, whether they required medication or not medication. Now, based on that, we checked this is the cohort, which is more or less similar with the difference in intraocular pressure. So our findings were that interleukin 18 was found to be more in glaucoma patients as compared to normal, and it was significant. Then, when we looked at the severity basis, we found that IL-18 levels were significantly higher in severe disease as compared to non-severe group. When we looked at the progression, that means VFI change, there also we found that IL-18 was found higher in the progressor groups as compared to the stable group, and it was significant. When we looked at the response to therapy, when patients responding poorly to AGM or medication were found to have higher IL-18 levels as compared to the ones which were responding well. And similarly, response to trabeculectomy also was found to be poor in patients who have higher IL-18 values. When we looked at the effect in vitro, so we looked at the cell lines and looked at different dosages of IL-18, if you see these higher doses, and the neurite length is being reduced. So we found that IL-18 was reducing the cell neurite length, but not affecting the viability. So to summarize, the IL-18 and disease association was clearly seen, and it was significantly higher values of IL-18 in patients with primary glaucoma and the severe form of disease, progressors, and non-responders. And also the similar findings we found in the in vitro cell lines, neuronal cell lines. So what do we know already about IL-18 is that the raised intraocular pressure in mouse models and dogs is associated with higher IL-18 levels, and IL-18 inhibitor is known to improve RGC survival in animal models. What this study adds is that IL-18 and glaucoma patients, there is an association of higher IL-18 levels with glaucoma and also the severe form of the disease, non-responders, and progressors. And we also found that in vitro, IL-18 is detrimental to the neurite length. So this study clearly bridges the species gap. We first time find in the human studies that IL-18 is linked. Now, what does it take us to the future? It can be useful in clinics for prognostication and risk stratification. We can do mechanistic and preclinical studies and have a new target, a therapeutic target in glaucoma patients. There are already drugs which are available which block IL-18 and are being used in trials like Crohn's disease, atopic dermatitis, and Still disease, etc. And these same drugs can be useful in future for glaucoma. There are IL-18 blockers which are already used for RGC survivors, and the existing drugs itself can be used for treatment in glaucoma in addition to our conventional glaucoma therapy. So that's an important step towards a new modality of treatment or next generation glaucoma therapy. With this, I would like to thank our clinical team, research team, and my co-investigators who have helped in the study, and also thanks a lot for listening to me.
Question, ma'am. The IL-18 levels, if they are high, they are toxic. And if they're too low also, then also, because they have some neuroprotective role also, it has been shown in the studies.
That's right.
So how do you modulate that, and how often do you take a sample to check whether the levels are in that level, the ideal level?
So when we are looking at IL-18 increased level in this particular group of patients for study purpose, it is in comparison to the normal group, which we have taken aqueous samples of cataract patients, which are being operated for cataract. So that is our control. The levels in the cataract patients and primary glaucoma patients were compared to that. Similarly, when we compare the severity, non-severity, everywhere baseline is that cataract patients where there are no other neurodegenerative or vascular diseases.
So how often do you take a sample to see? Have you given them treatment to them and seen that whether the levels have decreased or not?
No, so this is for the study purpose. This study was conducted in last 4 years. So all the patients who are undergoing trabeculectomy for primary glaucoma, the aqueous samples were taken to look at these levels. Now, when we translate into the clinical stuff, then we can actually predict. So at this point in time, the clinical application would be when we are operating a patient with trabeculectomy and take a aqueous sample, and you see that IL-18 levels are higher, you know this patient can fail. So you can look at other modalities of treatment, or can be more aggressive in treatment, or can give follow-up. The IL-18 blockers, which are available right now, are not yet tested for glaucoma. So that is the future therapeutic potential target. Right now, we can use it only for prognostication and risk stratification.
Thank you.
Be the cost of this?
Well, interestingly, now we have these biomarker kit, which is available in the sense that NN has created a biomarker kit where you can actually put the aqueous sample and get the results in, say, 45 minutes or so. That is going to be available. It's already at the level of distribution. So the cost is not going to be very high for the patients. The kit may cost, say, 20 to 25K at this point in time because that's a new thing that has come up.
Thank you.
Just one thing more. See, interleukin 18, specifically, it's significantly more in neovascular glaucoma and pseudoexclusion glaucoma compared to POEG. So, would you think this will have more relevance there rather than POEG? POEG is not supposed to be, the studies which have been conducted vis-a-vis the neovascular glaucoma, pseudoexclusion and POEG, there's not supposed to be that significant interleukin raising the levels.
Sir, incidentally, we are also doing, looking at the other molecules. So, in terms of neovascular glaucoma and where we have other secondary glaucomas, we found that VEGFs and TGF-beta has found to be more relevant as compared to IL-18. IL-18 has been found to be more relevant in primary glaucoma. So, this was beyond the scope of this study, so I did not present those molecules.
Have you specified the non-responders in your study?
Non-responders.
You just mentioned that they were non-responders, but did you specify what are the reasons for non-responders?
There are two types of non-responders, sir. When we looked at patients who were given IOP lowering drugs and they did not respond to drugs and had to undergo trabeculectomy over a 1-year follow-up.
I agree, but you should have at least specified in your study as to what you classified as non-responders and the severity and the non-severities. Thank you.
Okay,
I'm sorry.
thank you.
Okay,
Thank you, Rosie.
thanks.
Dr. Navdeep, over to you. Yeah, proceed.
Good morning, everyone. Today I'm here to talk on the impact of contrast sensitivity on driving behaviors in individuals with moderate to severe glaucoma. Contrast sensitivity is a key element of visual function and greatly influences daily activities like driving. Glaucoma often results in a gradual loss of peripheral vision and can impair contrast sensitivity. At present, there are 80 million individuals with glaucoma worldwide, and these numbers are plentiful to infer that probability of on-road drivers having this disease is high. Traditional contrast assessment tests like Pelli-Robson measures only central contrast sensitivity and are subject to various limitations. Meanwhile, Spaeth-Richmond contrast sensitivity test is an internet-based test which overcomes these drawbacks and measures both central and peripheral contrast sensitivity. The objectives of this current study are to explore the relationship between central as well as peripheral contrast sensitivity with driving behaviors in moderate to severe glaucoma patients. It is a cross-sectional analytical study which included 45 patients with moderate to severe glaucoma who are currently driving. The inclusion criteria was age more than 40 years, either gender, and best corrected visual acuity of 6/12 or better. Patients with other ocular diseases were excluded, and complete ocular examination was done. Spath-Richmond contrast sensitivity test is a computer-based test in which the patient is instructed to fixate on the central area of the testing screen and identify which of the areas appear different. Vertical square wave gratings appear for 0.3 seconds in one of the tested 5 areas. The range of contrast tested is 0 to 2.35 log units, which decreases approximately by 0.15 log units between the levels. It measures contrast in both all the central and peripheral areas, with maximum score being 100. This is a representative case of moderate glaucoma. The left eye shows inferior arcuate defect with total spark score of 66, and right eye shows hemiarcuate defect with paracentral scotoma and spark score of 60. The central image shows binocular estimate visual field acuity test, which has efficiency score of 109. This second is a representative case of severe glaucoma showing arcuate defects in both the eyes and spark score of 57 in right eye and 51 in left eye. The results were the average age was 61.76 years with male predominance, and most of the patients having primary open angle glaucoma. Contrast sensitivity in better eye was 2.8 with standard deviation of 0.24, and in worse eye was 1.95 with standard deviation of 0.27. The sparks in better eye was 66.58 with standard deviation of 9, and worse eye was 58.51, standard deviation of 9.67. The mean driving difficulty score measured by the driving habits questionnaire was 61.8. Lower score indicates greater difficulty. Mean driving space score was 2.98. Meanwhile, driving dependency score was 1.96. Now, on correlation of contrast with scores, dependency scores showed negative correlation with sparks. Driving difficulty scores and space scores showed positive correlations with sparks. Now, literature so far has only looked into the effect of contrast sensitivity loss on overall driving performance in glaucoma patients, and have concluded that patients with poor contrast had poor driving performances on driving circuits. The current study shows that individuals with poor contrast threshold in peripheral quadrants, especially upper right and lower right, in their worse eyes, experience more driving difficulties while driving in difficult situations and are more dependent on others for mobility. The limitations of this study are small sample size and predominance of male participants, and to enhance the credibility of our findings, a subsequent study employing objective assessments like driving stimulators can be used. To conclude, patients with glaucoma face many difficulties while driving, have lesser driving space, and are more dependent on others for mobility. This study reinforces the importance of incorporating contrast sensitivity assessment into overall evaluation of driving fitness, especially in glaucoma patients. Thank you.
Thank you. Meanwhile, Dr. Sardana, you can set up your talk here. So how do you differentiate just contrast versus contrast and visual fields, or glare sensitivity, or the other visual functions in these cases?
The visual field testing was done with the help of Umbri Visual Field 24-2. Binocular field testing, which kind of simulates the patient's perspective, was done with the help of binocular estimate visual field testing, which tests supra-threshold points 120 in the range of 120 degrees horizontally and 50 degrees vertically. And for contrast sensitivity, we use traditional method like Pelli-Robson, which only focuses on the central contrast sensitivity assessment. But the newer advances like Spath-Richmond contrast sensitivity test includes testing of peripheral as well as central area of contrast assessment around 30 degrees horizontally and 23.5 degrees vertically.
True, because in the real world scenario, that's going to matter more than just the central.
More than just central.
What would be your cutoff sparks level at which you would advise the patient not to drive at night?
So as per the normative data for these sparks, usually more than 70 sparks is considered normal.
So good morning, everyone. Thank you, APAO, for this opportunity. So the title of my study is Characterization of Peters Anomaly with Glaucoma, Clinical and UBM Perspectives. Coming to the background, as we all know, Peters anomaly is characterized by a shallow anterior chamber, synechia between iris and cornea, a central corneal opacity, and defect in the descent membrane. It has been classically subdivided into type 1, type 2, and Peters plus, and these are the known genes that we know of as of yet. So UBM is a high frequency ultrasound which visualizes anterior segment in opaque corneas, and a definitive diagnosis of a posterior descent defect is possible only by UBM. And studies have found high degree of consistency between UBM images and histological diagnosis in congenital corneal opacities. So our research question was, what is the clinical profile of Peters anomaly, and is there a prognostic value of UBM characteristic at presentation? Our aims were to describe the clinical profile of patients with Peters anomaly presenting over a 5-year period, to characterize and classify the various UBM findings in Peters anomaly, to correlate surgical outcome of patients with 1-year follow-up with the UBM findings at baseline, and to study the genetic profile in those undergoing genetic testing to assess the genotype-phenotype correlation. So ours was a retrospective cohort study over a 5-year period. We included children who had a congenital corneal opacity with a central clear area, presence of a descent defect on UBM, which was done using an open shell technique under general anesthesia, and following data was collected. The glaucoma outcome was graded as good, fair, and poor depending on the glaucoma control. So our outcome measures were as follows: demography and clinical features of Peters anomaly, UBM patterns of Peters anomaly, correlation of clinical and UBM pattern at baseline to the surgical outcome at 1 year. Coming to the results, so we had total of 21 children, that is 32 eyes over a 5-year period. The mean age of presentation was 1.31 months and the mean follow-up duration was 33 months. Coming to the laterality and gender, 48% of the cases were unilateral and 52% were bilateral, while 10 were females and 11 were males. So, over a 5-year period in 32 eyes, we noticed 4 distinct UBM patterns of Peters anomaly. So type A was only descent defect, where there was only a descent defect present. Type B UBM was descent and a posterior stromal defect. Type C was descent stromal defect with iridocorneal adhesions, and type D was a descent stromal defect with corneolenticular adhesions. So these were the 4 types that we noticed over a 5-year period in 32 eyes of Peters anomaly with glaucoma. And coming to the different presentations, type A was the most common, constituting 47% in our study. Type B was 34%, type C was 16%, and type D we only had 1 eye with corneolenticular adhesions. Coming to the follow-up results, we can see that the cornea clarity, intraocular pressure, and number of anti-glaucoma drugs decreased significantly at 1 year after surgery, while there was a significant decline in corneal thickness on UBM. The p-value was significant. We also did optical iridectomy in 15 of these eyes, and the eyes with optical iridectomy had a better visual acuity than eyes without optical iridectomy, but the p-value was not statistically significant. The glaucoma outcome at 1 year was graded as good, fair, and poor, with 25% of eyes having good outcome, 47% having fair outcome, and 28% having poor outcome. Coming to the correlation, when we correlated the type of UBM with the glaucoma outcome, we can see that the type A UBM had the best glaucoma outcomes, with 13 of the 15 eyes having good to fair outcome, followed by type C, which had similar results, and type B, which had the worst outcomes, with almost 50% of the patients having poor outcome. Genetic evaluation was done in 16 of these eyes, and we found 9 pathogenic variants with CYP1B1 mutation dominating the cohort. So to summarize, our study was one-of-a-kind study characterizing Peters anomaly with glaucoma. We classified UBM into 4 different types, with type A having the best outcomes and type B having the worst outcomes. Overall, 72% of the eyes had good to fair outcome in our study, and there was significant decline in corneal thickness after surgery. Peripheral optical iridectomy offers some visual rehabilitation in these children, and CYP1B1 mutations dominate in the North Indian cohort of Peters anomaly. So to conclude, this study provides novel insights into the UBM characteristics of Peters anomaly and helps in better prognostication for affected patients through UBM-based classification. Thank you.
Dr. Srushti, meanwhile, you can set yourself up on the other podium. Yeah, any questions?
Beautiful presentation. How many of them did you see were Peters plus? You had said unilateral, 58% were bilateral. How many were Peters plus?
There were 2 children and 3 eyes of Peters plus.
How was their prognosis different from the others?
We did not look specifically at the prognosis, but we graded
So
the glaucoma outcomes. So
Okay, so the Peters plus had which type of UBM characteristics? This the DM for defect or the stromal and or
Desmet plus stromal.
plus stromal?
All 3 had Desmet plus stromal. Yes.
So just 2 out of the 32 eyes were Peters plus.
3 eyes and 2 patients. Yes, ma'am.
So the single surgery, they were subjected to the same surgery, all of them?
Yes, sir. Sir, the surgery was depending on the cornea clarity. So, since Peters children usually have a bad cornea, so most of the children underwent a combined trab with trab. But in 2 eyes, we were able to manage an angle-based surgery, goniotomy, when there was a peripheral clearing and we can see the angle. So, all other eyes underwent a combined trab with trab.
All right, thank you.
Thank you.
Yeah, Dr. Srushti.
Can we have the next speaker?
Yeah, it's ready there.
Good morning, everyone. I shall be presenting a novel classification to prognosticate corneal changes in pediatric glaucoma using ultrasound biomicroscopy. As we know, corneal changes in pediatric glaucoma has varied etiologies and presentations like congenital ectropia on UVA, primary congenital glaucoma, Peters anomaly, congenital primary aphakia. Some may have a similar clinical presentation, but they vary in their ultrabiomicroscopic features. Hence, UBM acts as a window to provide in vivo imaging of anterior chamber despite opaque media. So, our aim was to classify these corneal changes in early childhood glaucoma into specific patterns using UBM and to analyze their prognostic value in predicting the outcome of surgery. So, ours was a retrospective cohort study of 6 years, including children from 0 to 6 years of age, with a minimum follow-up of 1 year and no prior surgical intervention. Examination on slit lamp or examination under anesthesia was done. Anterior segment details and IOP glaucoma severity scoring and UBM was done for all. And UBM pictures and clinical pictures at baseline were retrieved from the database. And we classified these corneal pictures into 6 types. Type A was diffuse corneal thickening. Type B was diffuse corneal thickening with intracorneal hyperreflectivity. Type C1 was Descemet membrane discontinuity. Type C2 was Descemet discontinuity with posterior stromal defect. Type D was intracorneal clefts, and type E where there was no definite pattern. Outcome measures were divided in corneal clarity and for IOP, which were then categorized further into good, fair and poor, and also a glaucoma severity scoring at presentation was done, which was then scored into mild, moderate and severe. So there were total eyes of 150 eyes of 80 patients, of which type A comprised of 49.3%, type B 25.3%, C1 and C2 6 and 14% respectively, and type D and E 2% each. And we could see that earliest presenting types were type C2 and type D, and on correlating with diagnosis, we could see that type A, majority of them corresponded with PCG, in type B, majority of them with congenital ectropia on UVA, type C1 and C2 with Peters, and type D with CEU. Comparing the corneal clarity at presentation versus at 1 year, we could see that type A and type E improved to a corneal clearing of grade 1, but type B and type D had a poor corneal clearing at 1 year. And also categorizing them into good, fair and poor, the corneal clearing at 1 year, type A had 73% of patients in good to fair category, whereas type B and type D had 70% of patients in the poor category. Comparing the IOP at baseline versus at 1 year, type A, type C1, type D, and type E improved to IOP of 18 millimeters of mercury at 1 year, but type B remained similar and had a poor IOP control at 1 year. Also, type A and type C1 had a good to fair IOP control and axial and stabilization at 1 year, but type B and type D required multiple interventions, surgical interventions, and had a poor IOP control at 1 year. So we could conclude that type B had the worst outcomes in terms of both IOP and corneal clearing, and it also left a central scar and had a poor prognosis. Type C2 and type D were the most severe types at presentation and presented the earliest. Type A had a good prognosis, and we could presume that type D could be a precursor of type B, as these two UBM pictures are of the same patient, where right eye had a intracorneal hyperreflectivity, whereas left eye had some intracorneal clefts. So we could conclude that baseline UBM can act as a prognostic indicator in predicting the surgical outcomes. Thank you.
Your membership number?
Set
Any
up, yes.
questions from
Dr.
the-
Bhavesh? Yeah, please.
Can we have your membership number? It's not written there. Are you a member?
No, sir.
No, so it cannot be judged.
Acha, oh, you're not a member. Was the previous student a member?
Everyone have
Oh,
their numbers
thanks, you've
mentioned,
checked it.
Yeah.
Thank you.
So, thank you so much. We cannot evaluate. यहाँ पे मैं right side में लिख
Good morning, everyone. I'm going to present my research topic, that is the comparison of GCL thickness in OCT and waveform on pattern ERG among the glaucoma suspect and healthy control. As we know, the standard automated perimetry is gold standard, but to detect the visual field, there should be at least 25% GCL loss should be there. Nowadays, it has been reported that pre-perimetric glaucoma cases can be assessed structurally by analyzing the GCL thickness of macula by OCT and functionally by pattern ERG. Regarding the pattern ERG, it has been reported that it can detect the defect at the stage of ganglion cell dysfunction, that is just before cell death. So our research question was, can GCL thickness in OCT and waveform in pattern ERG be used to diagnose the pre-perimetric glaucoma? Our primary objective was to compare the GCL thickness on OCT and implicit time and amplitude of P50 and 95 wave on pattern ERG among the glaucoma suspect and control group. Our secondary objective was to evaluate the correlation between GCL thickness and implicit time and amplitude of P50 and 95 wave among glaucoma suspect and healthy control. It was a hospital bed and cross-sectional study. The inclusion criteria was patient of age between 14 to 60 years, and in glaucoma suspect group, the patient having family history of glaucoma, CD ratio more than 0.5, asymmetry more than 0.02, diffuse or focal narrowing or sloping of the disc, but normal visual field or normal IOP, and patient with refractive error should be less than 4 diopter. In control group, we have included patient apparently normal finding. The calculated sample size was 50 in each group. Here we use for OCT, HRE OCT aspect release of Heidelberg, Germany, and for pattern ERG, we use Reti port scan 21 Ronald Concern, Germany. Regarding the result, the demographic distribution was similar in both the group. This is the unique of this study where we compare the GCL thickness in 2 zones, that is central 3 mm zone and peripheral 6 mm zone. This is the unique of our study. What we found in 3 mm circle zone, there is no significant difference in GCL thickness between glaucoma suspect and control group. But in 6 mm, that is the peripheral goggle thickness at macula, we found the significant decrease of GCL thickness in all quadrants, including the average in glaucoma suspect group in comparison to control group. Regarding the amplitude and implicit time of both wave, we found there is an increased implicit time of both P50 and 95 wave, and significant decreased amplitude of P50 wave, but non-significant decrease of amplitude of N95 wave. Regarding the correlation between GCL thickness and waveform, at the 3 mm circle zone, we found not any correlation between GCL thickness and waveform in pattern ERG. But at 6 mm circle zone, we found a significant weak positive correlation between the amplitude of P50 wave and GCL, and a weak negative correlation between implicit time of N95 wave and GCL thickness. When we compare our data to the previous reported regarding the GCL thickness, we found the similar reported by Zhang et al. And Su et al. But the difference is they use GC IPL thickness in comparison to our GCL thickness, and they map the whole macular area, where we compare the GCL thickness in 2 circle zones, that is the 3 mm circle zone and 6 mm circle zone, and we found only significant difference with 6 mm circle zone between the glaucoma suspect and control group. Regarding the pattern ERG, the amplitude of P50 wave we found significant decrease and significant increase of implicit time of P50 wave similar reported by Gion et al. But Vanek et al. And Jung et al. Reported no changes between the suspect and control group. Regarding the implicit time of N95 wave, we found non-significant decrease of amplitude and significantly increase of implicit time, similarly reported by the Gion et al., Vanek et al., and Jung et al. Regarding the correlation, we found there is a very weak positive correlation between the amplitude of both wave to the ganglion cell thickness. But regarding the implicit time, we found a contrast reverse result, that is a weak positive correlation. This should be negative correlation. This is also reported by Jung et al. So our conclusion is the structurally GCL thickness analysis as peripheral macular region, that is 6 mm circle zone, and functionally by pattern ERG can use to diagnose the perimetric glaucoma. Thank you.
Dr. Anjali, you can get ready in the meanwhile.
So, do you think that PERG would replace OCT, or is it feasible that it will detect glaucoma earlier than?
Yes, recording is very difficult, so it is not commercially available. That's why it is, and it is very time-taking procedure. That's why at present it is very difficult to replace the OCT or visual field at present scenario.
Would you say that PRG is not very easy to do in glaucoma suspects? So if you have OCT, so would you just go for a GCL and not a circumpapillary RNFL in future, because this is more sensitive?
I think, ma'am, it should be more sensitive than GCL, but previously reported that both are equal, GCL IPL complex and
but
GCL.
Have you compared macular GCC compared to circumpapillary RNFL?
No, previous reported already published. There
Okay.
is no significant difference between diagnostic ability of GCL.
So what is your take-home message? What is your conclusion?
My take-home message is that peripheral GCL mapping can help to early diagnose in cases of pre-perimetric glaucoma, not central.
Okay.
And the pattern ERG can be used to diagnose.
Okay, thank you. Can we have
To
the
diagnose
next?
what?
Pre-perimetric glaucoma, that is.
See, in this, in this
Can we have the
ERG was
next
not
speaker
affected
on
in
the-
any of your glaucoma suspect. And usually only the N95 amplitude is usually affected. In your case, all the implicit times are also affected. Can you explain why? None of the studies have shown
Yes,
any association with
ideally
either
yes.
P50 or implicit times.
Yes, sir.
Yours-
Okay.
Yeah.
Ideally, there should be only N95 should be decreased in comparison to P50 amplitude. But in severe cases or some cases, it has been reported that both can be reduced.
Okay, thank
Is
you.
Dr. Anjali there? There's Dr. Harsha, you can come.
Thank you.
Dr. Anjali Pathak is there?
I think she's.
No. Then we have Dr. Harsha. Dr. Harsha. Dr. Gazella. Dr. Gazella,
Yeah,
please come
yeah,
on the
yeah.
podium. Please come on the podium. Is Dr. Saswati here? Please be ready for the next then. You are?
Dr. Harsha.
Dr. Harsha is there.
Dr.
Next
Harsha.
after that you.
Okay, please
Yeah.
come.
Dr. Harsha's presentation, please.
Good morning, everyone. Today, I'll be presenting on the assessment of foveal avascular zone area changes after trabeculectomy in glaucoma patients using OCT angiography. Foveal avascular zone is a round capillary-free zone within the macula, which is conventionally assessed using fundus fluorescein angiography, which is an invasive investigation. New modalities like OCT angiography, which is non-invasive, can also be employed to assess foveal avascular zone. Now, OCTA-based phase area changes may be candidate biomarker to study changes in perifoveal microcirculation following glaucoma surgery. An enlargement of phase area is indicative of retinal ischemia, and a decrease in phase area is indicative of an improved retinal perfusion. There is only limited evidence on the effect of intraocular pressure reduction by trabeculectomy on phase area and foveal microcirculation, especially in case of primary angle closure glaucoma patients. Our study aims to assess changes in phase area in both primary open angle and primary angle closure glaucoma patients following trabeculectomy using OCT angiography, and also to correlate these changes in phase area with changes in IOP, foveal sensitivity, and visual field mean deviation. This was a prospective observational study which happened for a period of 1 year in Glaucoma Department of Contrast Eye Hospital, Calicut. We included patients with primary open angle and primary angle closure glaucoma who had clinical indications for phacotrabeculectomy. We excluded patients with ocular pathologies that could bias the phase area, such as diabetic retinopathy, vein occlusion, macular edema, ocular trauma, uveitis, and also trabeculectomy with complications and poor quality scans. A proper detailed history, anterior and posterior segment evaluation, IOP measurement using Goldman applanation tonometry, gonioscopy, HFA24-2 and OCT RNFL, and OCTA was done. OCT angiography was done using Heidelberg Spectralis HRA to assess the phase area both pre-operatively and 3 months post-operatively, both in superficial and deep vascular plexus. The area was measured by tracing the inner loci of the capillaries by 2 examiners independently, and the mean value was taken. Coming to the results of the study, the total sample size was 41, with 23 primary open angle glaucoma patients and 18 primary angle closure glaucoma patients. So around 70% had severe glaucoma. In primary open angle glaucoma group, the intraocular pressure decreased from 22 to 15, and in angle closure glaucoma group, it reduced from 23 to 15. The mean change was 7, and this was statistically significant. Coming to the phase area changes in the superficial vascular plex. Both in primary open angle and primary angle closure glaucoma group, there was a change, but this was statistically significant only in the open angle glaucoma group. Coming to the change in phase area in the deep vascular plexus preoperatively and postoperatively following trabeculectomy, there was a statistically significant reduction in both the groups, and the change in open angle group was 0.073 and in angle closure group was 0.053. The correlation between change in intraocular pressure and change in phase area in the superficial vascular plexus was weak, negative, and not statistically significant. In SVP, the correlation between change in phase area and change in IOP in the DVP was not statistically significant for the primary open angle glaucoma, but in PACG, there was a negative correlation which was statistically significant. Now, the correlation between change in phase area and foveal sensitivity was a weak positive correlation. Also was the case with HFA mean deviation. So our study had a sample of 41 for duration of, we assessed patients for duration of 3 months, and we found phase area was decreased both in SVP and DVP in both PACG and POAG patients. A study by Takui et al. Says phase area was decreased in SVP, and by Heyang et al. Says there was significant decrease in phase area in DVP. Another study by Tu Wang et al., they said there was an increase in phase area at 1 month, which decreased in 3 months, but reverted back to baseline at 1 year. So conclusions, foveal avascular zone area in both superficial and deep vascular plexus was decreased after combined cataract and trabeculectomy surgery in both PACG and POAG patients. The significant reduction in IOP and the associated changes in phase area suggest that trabeculectomy may improve retinal perfusion. So the study strengthens the understanding of how lowering IOP with trabeculectomy affects retinal vascular health by employing a non-invasive modality. And also it highlighted the differential vascular response in SVP and DVP. The values might have been influenced by cataract extraction done along with trabeculectomy, and patients were followed for a shorter duration, and if phase area was manually traced, and stoppage of anti-glaucoma medication post-surgery could have also affected the values. Thank you.
So yeah, thank you. So was the sample size adequate to take this determination, and what was the duration of the glaucoma prior to this? Did that make a difference? Did you look at that? Because
duration of
glaucoma.
Of the
Duration
glaucoma
of the
itself,
disease.
right? Changes to the SVP, DVP would also depend upon.
Yes, sir.
Yeah.
And also the follow-up period was like we are actually continuing the study. Like we could get the results for only 3 months. There was a study which showed that at 1 year, the result had actually, the phase area had gone back to the baseline. So we are yet to derive results out of that. Like these are only the results of 3 months follow-up actually.
Yeah, but I think the study needs to be a little better powered in terms of the sample for this. If you looked at all the other studies, the sizes are much bigger.
So could you correlate the phase area improvement post IOP control with the visual acuity improvement? Because that's what the patient is bothered with. How much is the vision improved? I assume IOP was controlled for all. So what was the visual acuity improvement if the vascular perfusion had improved? Did the vision improve?
Actually, it was not. Actually, we had 70% of the patients falling into the severe glaucoma category.
Right.
So the improvement in vision was not that significant. The improvement could also be due to the cataract extraction, which had happened along with the trabeculectomy.
So what were the clinical implications of the improvement in the FAS area? Vascular permeability. Any clinical implications?
One thing is like an advantage for trabeculectomy because a sudden decrease in intraocular pressure, which was not possible with maximum anti-glaucoma medication. This could have improved the ocular blood flow and the ocular perfusion pressure, so thereby increasing the perfusion to the retina. So it's advantageous in terms of vascular supply to the retina.
So how did you assess that? Other than FAS area, any other thing, visual field or visual acuity or contrast, anything which improved? It's okay. Any other questions from the house?
One question. The lenticulopacities are known to affect the FAS area, and you have done phacotrabeculectomy in all the cases.
Yes,
Do you think that will affect the result outcome?
Yes, sir. That's a confounding factor actually.
It's a very significant confounding factor.
Because your topic says after trabeculectomy, but your reading says that it is after phacotrabeculectomy. Because after phacotrabeculectomy, there can be more inflammation and the duration after which that you have done an AIOS2025 to see the FAS area is also important. That how long after your surgery would you be doing that? So you said it's a 3-month study.
We evaluated
so I
at
don't
3
think
months only.
all the cases were done at one time and after 3 months you did a FAS.
No,
Yes.
So
the longer
it could
follow-up
have
will
been
tell, I think, once
slightly
you do
longer till the time you could see what the effect is.
Yes, sir.
All right, thank you. Dr. Gazella, over to you. And meanwhile, Dr. Saswati, be ready next
Just
on
a
this
minute.
podium.
This session is till 10:30. So just want to take a roll check. How many are there? So then we can keep discussing. We have half an hour left. And do we have Dr. Tarud, Dr. Gazella?
Yes.
You're there. Right. Do we have Dr. Saswati Sen? Please raise your hand. You are there. And do we have Mr. Suresh Kumar Yadav? He's not there.
Yeah, he's there.
Sorry, he's there. Okay, I didn't see you. My bad. Your no membership number is not there, but he can present, but it won't be competitive. Then you have Dr. Sahiban Sabarwal. Is she here? You are there. Okay. Then you have Dr. Shubhangi. You are there. And we have, last is not
Vaishali.
least, Dr. Vaishali.
She's there.
So all of you are there, and we have, that means 1, 2, 3, 4, 5, 6 people, and we have 30 minutes. So we'll have to restrict one question per.
Yeah.
Please carry on.
Dr. Saswati, you can be ready next as soon as Dr. Gazella. Yeah, Dr. Gazella,
Good
over.
morning,
Just be
everyone.
ready on the podium.
Yeah, please.
It's not moving. So these are the abbreviations which I'll be using today. We all know that CCT, higher the CCT, there is overestimation of IOP, and the lower the CCT, there is underestimation of IOP. So why is CCT important? For accurate IOP measurement, to risk stratify the patients, for clinical decision making, and to prevent misdiagnosis or inappropriate treatment. It has a role in NTG and OHT, and even for patients who are undergoing refractive surgery to either classify them as OHT or glaucoma suspects. But the lacunae in literature is that ultrasonic pachymetry has a disadvantage of being a contact technique, and there have been multiple studies comparing ultrasonic and non-contact, as seen here. Most of them have been done on healthy eyes, except for one study which did on glaucoma patients, just like in our study. And all of them have contradicting results, which some showing ultrasonic showing lesser CCT, some showing non-contact showing lower, some show no difference, and some show that both are highly reproducible. Some show that the non-contact is more consistent. So that's why we decided to compare the repeatability of CCT taken by non-contact specular microscope and to assess its agreement with ultrasonic pachymeter in glaucoma patients. It's a cross-sectional analytical study conducted at RML Hospital. So this is the inclusion criteria of OHT, POAG, PACG, and controls according to the standard definitions. Exclusion criteria was diseased corneas like edema, infections, opacities, or any curvature abnormalities, dystrophies, severe dry eye, contact lens wearers, history of previous ocular surgery, or those not giving consent. In the methodology, after we did a preliminary examination and divided the patients, a CCT was taken by 2 observers, And the non-contact, 3 readings were taken, and an average was taken of these 3, and ultrasonic 5 readings, and the lowest and highest were excluded, and the average of the middle 3 were taken. And the readings were taken between 9 a.m. to 4 p.m., 3 hours after awakening, and within 1 hour of each other. So we used descriptive statistics, Bland-Allman plots, and intra-class correlation coefficient, and Cronbach's alpha test to see the magnitude of correlation. So here, as we can see, the average CCT is showing consistently lower in the non-contact specular microscope. And for inter-observer variation, for both observer 1 and observer 2, all the levels are quite high in both Cronbach alpha and ICC. And even for intra-observer variation, for the total data, also showing all higher values, and even after dividing them into groups also. So in the Bland-Allman plots, this is of the whole data. It's showing that most of the data is nearby to the mean, and within the limits of agreement with very few outliers. And for POAG, you can see here that chart is very similar in both the eyes, as well as PACG, showing high correlation, and even for OHT, and even for controls, all being nearby to the mean and with the limits of agreement. So the strengths of our study is the first study to compare CCT and POAG, PACG, OHT with control eyes in Indian population, and is the first study to use more than one observer with multiple readings for ultrasonic and non-contact. But the limitations are that it is limited to those more than 40 years with healthy corneas, and it cannot be generalized to other ethnic groups. So we can conclude that CCT measurements on glaucomatous eyes with ultrasonic pachymeter were significantly thicker than with non-contact specular microscope. Although the non-contact specular microscope can measure CCT with excellent repeatability and reproducibility, it can yet be used interchangeably with ultrasonic. And in the future, studies can be conducted with larger sample size, wider inclusion criteria, wider age range, and can include other instruments also for checking CCT. These are the references. Thank you.
One question, please. You can start. One question. Anybody wants to ask one?
You said the Bland-Allman graph shows good agreement, but in the end said they are not interchangeable. If you think it's a very good agreement, then why should it not be interchangeable?
Intra-observer variation. So that Bland-Allman was showing how much observer 1 and observer 2 were agreeing with each other.
I'm talking about regarding the interchangeability of the readings of ultrasonic and the non-contact CCT measurements. You said it cannot be used interchangeably.
Because
if the agreement between these two are good, then why can't it be used interchangeably?
That graph was showing for ultrasonic and for non-contact, but it was showing consistently lower for the non-contact. Thank you.
We have the next speaker, please. So Dr. Manju, be ready with the next question to her. So we'll just take one question.
A very good morning to all. I'll be presenting our study on comparing the retinal nerve fiber layer and Brooks membrane opening minimum rim width measurement thickness between the glaucoma and this suspect patients using OCT. We know that glaucoma is a progressive optic neuropathy where there occurs the loss of retinal ganglion cells and the thinning of the retinal nerve fiber layer. And this cell death occurs even before it's apparent to the patient in terms of visual damage. So we have found the new parameter, that is the Brooks membrane opening minimum rim width measurement, can be an indicator of glaucomatous damage as well. So the purpose of our study was to measure the retinal nerve fiber layer thickness and Brooks membrane opening and minimum rim width measurement on OCT in this suspect's patient and then compare it with the glaucoma patients. And also to find out the association of intraocular pressure and visual field changes with these OCT parameters. It was a prospective study. It was conducted over 12 months. We took 87 patients in the glaucoma group and 88 in the dysuspect group. A comprehensive ophthalmological examination was done for all. Dysuspect patients were defined as patients which had a cup disc ratio greater than 0.5 and one eye at least, or a difference of 0.2 between the two groups, but they had an IOP of less than 20 millimeter. So these are our baseline parameters where there was a significant difference except for the gender between both the groups. On comparing quadrant-wise analysis of the retinal nerve fiber layer and the Brooks membrane opening minimum rim width, we found that the readings in the infratemporal quadrant and the supratemporal quadrant of the RNFL were higher, whereas the nasal part of the disc was found to be thicker in cases of readings of the Brooks membrane opening and minimum rim width. And all the values were significant between both the groups. When we correlated the intraocular pressure with these measurements, as usual, we found that the intraocular pressure was negatively correlated, while retinal nerve fiber layer and BMO MRW measurements were positively correlated, and this value was significant, which means that the change in RNFL and the Brooks membrane opening and minimum rim width, the change that occurs in the value of these two parameters for a change in with the glaucoma progression is significant. Similarly, we also found similar results for correlation of IOP with these two parameters, where the values were significant for comparison between RNFL and BMO MRW. When we compared visual field loss with both these parameters, within DIS suspects, there was not much visual field loss. So we compared mild, moderate, and severe visual field loss based on mean deviation on the visual field. And we found that the values, the difference in change from mild to moderate and moderate to severe, they were all significant in both the groups with the visual field loss. But on plotting the graph, we found that the RNFL graph was steeper than the BMO MRW graph for the visual field change, which means that for the same visual field change, RNFL loss was more predictable or had a pronounced change as compared to the Brooks membrane opening minimum rim width. We know that RNFL assesses the thickness of the nerve fiber layer itself, while the smallest distance between the opening of the Brooks membrane to the internal limiting membrane gives us the measurement of the BMO MRW. So when both clinical and functional damage is correlated, the subtle glaucomatous damage in various quadrants can be picked up, because in our results we found that both the parameters, they show changes in different quadrants. It's not necessary that they find the changes in the same quadrant. And BMO MRW is also more effective in ruling out glaucoma in case of different types of discs. It has been shown in other studies. Now, taking both the values together, we can increase the specificity of the diagnosis. But if we take this or that when we are confused between different groups, maybe it will increase the sensitivity of the tests. So combining these findings with the visual field changes will improve the prognostic and diagnostic ability of the tests. These are some studies which have shown that BMO MRW is a reliable parameter which has discriminated perimetric, pre-perimetric glaucomas and is highly consistent across different examiners too. So the take-home message is glaucoma is often diagnosed as a stage when damage has already started and is irreversible. So the ability to differentiate between healthy individuals, DIS suspects, and confirmed glaucoma patients is a critical aspect. So early diagnosis leads to better prevention and better prognosis. And this can be possible by incorporating RNFL, BMO MRW measurement, and visual field changes together. So incorporating it into our daily practice will help not only differentiate it from other optic neuropathies from glaucoma, but also help us prevent the visual loss. These are my references. Thank you.
So, do you think how frequent should we do it if you see once? How frequent should we assess?
Ma'am, as of now, when we conducted the study, we have been using, in that the spectralis OCT, it's actually possible. When you take the OCT reading, we can get the RNFL and
Mr.
the BMO
Suresh,
MRW
please, on the
measurements
dais.
side by side.
Podium.
So it's possible in the same setting only. It's not a difficult thing to do. When we are ordering a OCT investigation for the patient, it can be done in the same setting when we are using the machine.
In future for mild, moderate, and severe myopia also in that situation.
Yes, ma'am.
Yeah.
Some studies have shown that area of, in myopic patients, if there is a greater area concern, maybe BMO MRW will be less reliable, but when it's early damage, it can be detected early.
Thank you. Keeping the myopia epidemic in mind, I think it's a very relevant thing. Thank you. Can we have the next speaker, Mr. Suresh? And he would not be in the competitive session because you don't have membership number, right?
Yeah.
So you would just present. So that's for all the mic.
Good morning, everyone. Today I will speak about the risk stratification of biometric factor in early onset primary angle closure disease. Myself, Dr. Suresh Yadav from the RP Center, AIOS, New Delhi. As we all know, adult onset primary angle closure glaucoma is the leading cause of irreversible blindness. However, there's very limited study on early onset primary angle closure disease. That doesn't have very much of known studies. Since there was very limited study on early onset primary angle closure disease and mostly I'll focus on the etiology of the disease only, there is only one study which has evaluated some factors of the biometric in the early onset primary angle closure glaucoma. So since there was no study that has been looked into the factor that lead to the development of glaucoma in eye with early onset primary angle closure suspect and eye with early onset primary angle closure. So we aim to identify the potential biometric risk factor that could seen as developing angle closure glaucoma in the eye with early onset primary closure suspect. In this cross-sectional observational study, we include the patient age between 20 to 40 years diagnosed with the primary angle closure disease, and we exclude the patient with the prior laser peripheral iotomy, history of ocular trauma or surgery. We also exclude the cases with the secondary angle closure and eyes those have non-ophthalmos and asperophakia. A detailed ophthalmic evaluation was carried out along with the gonioscopic evaluation to all the patients. We also did ultrasound biomicroscopy along with the STAR 360 analysis to look into the mechanism involved. So mechanism of angle closure was primarily relative pupillary block, pseudoplateau iris configuration, plateau iris configuration, and an exaggerated lens wall. Similar to ICGO classification proposed for the adult onset primary angle closure disease, we opt a similar criteria and classify our patient into early onset primary angle closure suspect, early onset primary angle closure, and early onset primary angle closure glaucoma groups. Coming to the result, the mechanism of angle closure was predominated by non-pupillary block mechanism, which includes the pseudoplateau iris configuration and plateau iris configuration. In the eyes with the early onset primary angle closure disease, this is compared to the relative pupillary block and exaggerated lens wall. So we did not find any significant change in the refractive status among the subgroup of the eyes. While comparing the biometric and anterior segment OCT parameter of eye of different stages, we found anterior chamber depth was least in the eye with early onset primary angle closure glaucoma and significant with the shorter axial length in this group of the eye. Early onset primary angle closure glaucoma has a thicker lens thickness and so the higher lens wall along with the lower relative lens position. So all the mechanisms which lead to develop angle closure were more pronounced in the eyes with the early onset primary angle closure glaucoma groups. So coming to the main aim of this study to identify the potential risk factor, we found shallow anterior chamber depth as the most robust predictor for early onset primary angle closure glaucoma, followed by the lens thickness and lens vault. So despite of some limitation, this study represents the milestone in the research of early onset primary angle closure disease by having the highest number of eyes study and also pioneering in identifying the potential biometric risk factor for developing angle closure glaucoma in the eye with early onset primary angle closure disease. As stated earlier, non-pupillary block mechanism is the most common cause of angle closure glaucoma in the early onset primary angle closure disease. A shallow anterior chamber depth identifies the most robust predictor for early onset primary angle closure glaucoma, followed by the lens thickness and lens vault. So we can conclude as a thicker and more anteriorly placed crystalline lens was the key anatomical factor associated with the shallow anterior chamber depth, and that could lead to rapid development of glaucomatous optic neuropathy in the eye with early onset primary angle closure disease. Thank you.
You said it's a strong predictor of glaucoma. See, a cross-section study cannot be a strong predictor of glaucoma. You've done a cross-sectional study, not a longitudinal study.
This was the limitation of our study. The longitudinal should be the ideal setting, but this can lead to...
It's not ideal setting, except for no diagnosing or saying this is a risk factor, you have to do a longitudinal study. A cross-section study is not capable of that.
Yes, sir, that is our limitation of this study, but that could lead to stretch the year of the study.
Just tell me, how did you diagnose, how did you define early onset? What was the cutoff for early onset?
Early onset is defined as the onset before the age of, before the 40 years.
40, thank you, thank you. Dr. Sahiban, please.
Good
Dr.
morning,
Digvijay,
everyone.
please ask the question. Be prepared.
So my topic today is initial experiences with iStent and iStent Inject in Indian eyes. This is a pilot study which is based on stratified outcomes and safety. So just to give a background, iStent is a minimally invasive glaucoma surgery device We had the generation 1 eye stent, which was one L-shaped stent to be placed in one eye of a patient. Then came the generation 2, where there were 2 dumbbell-shaped eye stents to be placed in one eye of a patient. So the principle basically, by and large, is about trabecular meshwork bypass, wherein if you place the stents at the level of the trabecular meshwork, which is obstructed in POAG, you tend to create a passage out for the aqueous from the anterior chamber into the Schlemm's canal. So the aim of our study was to see if iStent inject was effective in reducing intraocular pressure, if it was effective in reducing the number of anti-glaucoma medications, was it safe, and how did it compare to the G1 stents. This was a retrospective case studies. We took 15 eyes of G2 stents and 11 of G1 and followed them through 6 months. Primary outcome measure was the percentage IOP drop and percentage AGM reduction. Complete success was defined as IOP less than 21 with no medications, qualified less than 21 with AGMs, and failure if the IOP could not be controlled and was beyond 21 with AGMs or need for additional filtration surgery. We used the pair sample t-test to compare IOP and the number of glaucoma medications pre and post-operatively, and statistical significance value was taken as p less than 0.5. The baseline IOP in the G1 group was 20.55 and the baseline AGM was 1.82. In G2 it was 22.06 and the AGM baseline was 3.06. They were both not statistically significant when it compared the two groups. The effect on IOP with G1 at the end of 6 months was only about 0.5% drop in IOP. With G2 stents, there was a 32% drop in IOP seen at the end of 6 months. When it came to the effect on AGM, there was an 80% drop in the need of anti-glaucoma medications at the end of 6 months with G1 stents and about 70% with G2 stents. Complete success was 64%, which means that with the G1 stents, when all the patients were on some or the other AGMs, at the end of 6 months, 64% were free of anti-glaucoma medications, and in the G2 group, 57% were free of anti-glaucoma medications. We also stratified them with the stage of disease and saw that there was only statistically significant reduction in anti-glaucoma medications in the mild to moderate and in the severe group with both G1 and G2, while there was none in reduction of IOP. Also, when compared with phaco and without phaco, when G2 stents were used with phaco, there was a significant drop in IOP. And when the G2 stents were used with or without phaco, there was still a significant drop in anti-glaucoma medications. The safety profile was high. We saw in about 20% post-operative hyphema. There were also IOP spikes in about 17% of our cases, and 1 each of steroid response, iridocyclitis, pigment dispersion, iris chaffing. Visual acuity was better than preoperatively in 93.33% of patients, and visual fields remained stable. So we conclude that iStent inject is more effective in reducing both IOP and AGMs at the end of 6 months when compared to G1 stents. Both had good safety profile. G1 significantly reduced only the anti-glaucoma medication load in mild to moderate group, whereas the G2 in all stages of glaucoma was successful in reducing the anti-glaucoma medication load. Higher baseline IOP was associated with larger reductions in IOP. So in conclusion, I think G2 iStent devices are suitable for use in patients in whom medicated IOP is controlled preoperatively and only a reduction in anti-glaucoma medication is desired. Why this study matters is because there is absolutely no literature available yet of the outcomes of iStent in Indian eyes. The study limitations, however, are this is a non-randomized study with no control group. It is a heterogeneous cohort. However, this does represent a real-world clinician's glaucoma population and insights into early safety and efficacy of iStent inject eyes in Indian eyes. Thank you.
Thank you. A nice study. I would just like to ask one question: that what are the methods, the investigative procedures that you do pre-operatively to ensure
Dr.
that
Shubhangi on
the
the
success
podium.
is more in such cases? Because there is like the chances of failure are quite high in these cases in the use of iStent.
Right. So none really, sir. There are no investigations which can ensure that your MIGS procedure will be successful. However, we do have an indication criteria, which is usually a cutoff of 30 millimeters of mercury IOP, not higher than that, which is a medicated IOP. Or if you are, if the patient is suffering from AGM allergies, intolerance, or for any particular cause, you want to take the AGMs off the patients, particularly preferred with phaco. So if you have a glaucoma patient coming to you for a cataract surgery, you give them the option of combining them with MIGS so that the AGM load can come down.
Actually, it is the drugs that are acting on the trabecular meshwork. If they are working, then the eye stents are likely to work more.
Correct.
And the last speaker, please, if you could be on the podium, then we would have a, yeah, thank you. Vijay, you haven't asked a question. You have to ask the question this time. Dr. Digvijay, question to her afterwards.
Good morning, everyone. I'll be talking about evaluation of the fellow eyes of phacomorphic glaucoma. As we all know that phacomorphic glaucoma is an ophthalmic emergency where the patient presents with painful eye, and we have raised intraocular pressure, a shallow anterior chamber, and total intermittent cataract, and the management involves the control of intraocular pressure and cataract extraction. Now, as per the previous literature, the common risk factors for developing phacomorphic glaucoma are advanced age, a female gender, a shorter axial length, and a shallow anterior chamber. As we can see that these are the risk factors which are also shared, and these are going to be present bilaterally, and these are the risk factors which are also shared by the angle closure diseases. And out of all these, the shallow anterior chamber depth is the one which is having a higher preponderance or having a higher risk of converting into an angle closure disease. So considering the overlapping risk factors between these two diseases, we aim to evaluate the incidence of angle closure characteristics in the fellow eyes of patients with phacomorphic glaucoma. So retrospectively, we collected the data of the patients who were diagnosed with phacomorphic glaucoma between January 2020 till September 2024, and we collected the demographic profile as well as for the fellow eye, visual acuity, intraocular pressure with Goldman applanation tonometer, anterior chamber grading on slit lamp, gonioscopy, lens status, disc status, axial length, anterior chamber depth, and lens thickness was noted. So in the 57 months of study duration, there were 87 cases of phacomorphic glaucoma that were identified. The average age of presentation was 62 years. As we can see that around 40% patients were falling between the age group of 61 to 70, and the remaining 22% were falling on either side of this. Most of the patients, 64%, were female. The best corrected visual acuity in the fellow eye in almost 68% patients was better than 20/60, and when coming to the intraocular pressure, almost 94% patients were having an intraocular pressure of less than 21 mmHg. Coming to the lens status, around 49% of the patients were having a cataract in the fellow eye, 45% patients were having a posterior chamber lens in the fellow eye, and 6% patients were having a clear lens in the fellow eye. Now, when evaluating the anterior chamber grading and gonioscopy, we excluded the eye who have already underwent an intraocular procedure, as this is going to change the normal anatomy of the eye. So the patients who were having a cataract or a clear lens in the fellow eye, we documented the anterior chamber grading and gonioscopy for them. So when we see on this, around 27% patients were having a grade 1 angle on slit lamp evaluation, around 17% patients were having a grade 2, 6% patients were having a grade 3, and around 50% patients were having a grade 4 angle on anterior chamber grading. For gonioscopy, in the patients with cataract and clear lens, the gonioscopy was performed in around 36 patients only, and in 12 patients, the gonioscopy was not documented. Out of the 36 patients who have underwent a gonioscopic evaluations, the angles were open in 19 eyes, and that is amounting to 53%, and around 47% of the fellow eyes were having a closed angles. If we look onto the axial length was available only in the 19 eyes, and it was around 3.06 mm, and the average lens thickness was around 4.25 mm in the fellow eyes. As we can see that in the previous literature as by Mohagni et al., they have concluded that around 75% of the fellow eyes of the phacomorphic glaucomas, they do have closed angles on gonioscopy. And Keels et al. Have also documented that a shallow interior chamber is one of the risk factors in patients with mature cataract, which can develop to phacomorphic glaucoma. In our studies, around 47% of the fellow eyes of the phacomorphic glaucoma were having a closed angles on gonioscopy. So my take-home message is that a gonioscopic evaluation of the fellow eyes of the phacomorphic glaucoma should always be done, and if possible, a prophylactic peripheral iridotomy can be planned in the fellow eyes of the patients of phacomorphic glaucoma if a shallow AC also noted. Thank you.
Thank you. Thank you,
We have the
Roshani.
next speaker, and we'll take the questions at the end after the group
This is,
photo.
I think, something that we do anticipate that there will be a shallow AC and angle closure. But how about the lenses? I mean, what was the lens thickness like, or what the intumescent? Did you measure that or grade that? Because that's probably more important.
Yes, sir. Actually, the lens thickness in the contralateral eye was available only in the 18 patients, limitation being the retrospective study. In the data that was available, the lens thickness was enlarged. It was around 4.25 mm.
So why do you postulate one of them went into phacomorphic then? Is it they delayed the procedure, or because there's also female preponderance? So do you have any hypothesis on that?
Sorry, sir, I couldn't get the question.
So we are seeing that there is one of the eyes went into a phacomorphic glaucoma, right? The other eye, you're looking at the fellow eye. So did we see what the cause for asymmetry was? Was it a delayed procedure, like one was pseudophakic already, and therefore the other eye probably got, they didn't get it operated for a long
that
time?
was a significant reason because 50% patients were having PCL implantation in the fellow eyes. And the other eye was presented as a phacomorphic glaucoma. So this could be the cause that they have presented late in this.
Yeah, so that's a postulated thing that's been looked at. Thank you.
Can we have the last but not the least speaker? Yeah, and the group picture for all these speakers be there.
A very good morning to respected judges and all my colleagues. I am Dr. Vishali, and I'll be presenting my paper on the topic Yoga and IOP, Our Experience. Thank you APO for providing me this opportunity, and first of all I would like to thank my guide Dr. Manisha Rathi ma'am and Sumit Sachdeva sir for guiding me and helping me out. Yoga. Yoga is a century-old practice with physical and mental health benefits, and it is gaining global acceptance worldwide. However, there is very limited evidence which exists on the specific effects of yoga on ocular physiology such as intraocular pressure. So we conducted this study to evaluate the acute effects of yoga on IOP in healthy individuals and to identify that which yogic poses are beneficial and which should be avoided in glaucoma patients. As was a cross-sectional prospective observational study which included 50 healthy individuals more than 18 years of age who were willing to be a part of my study, and we excluded those who were not willing to be a part of my study, less than 18 years of age, and pregnant females. We made 7 groups of 7 individuals each who were instructed to perform 7 yoga asanas for 2 minutes each, and then the IOP was measured using non-contact tonometer 2 minutes post-yogic session. These were the asanas which were included: Anulom Vilom, Vipreet Karani, Uttanasana, Adho Mukshvanasana, Tratak Kriya, Kapalbhati, and Bhastrika Pranayama. We utilized SPSS version 29.0 for statistical significance and applied paired t-test for intra-group comparisons and post-hoc Tukey test for inter-group comparisons. A p-value of less than 0.05 was considered for statistical significance. After all this cumbersome exercise, here are the results. In Adho Mukshvanasana, Tratak Kriya and Anulom Vilom, the IOP reduced significantly. However, it has increased significantly in Uttanasana, Kapalbhati, and Bhastrika. Similar are the results of left eye. Coming to each yogasana individually, in Adho Mukshvanasana, the mean IOP before yoga was 16.29 with a standard deviation of 1.6, and the mean IOP after yoga was 15.86 with standard deviation of 2.12, giving us a p-value of 0.2, hence it was statistically insignificant. Similarly, the results of every yogasana were interpreted. So the mean age of participants was 35.98 with plus minus 11.45 years with range from 18 to 65 years with a gender ratio of 0.88:1. The key findings are that there is a significant decrease observed after Tratak Kriya and Anulom Vilom, and there is a temporary rise noted after Bhastrika, Kapalbhati, and Uttanasana. So the positive impact was that in Tratak Kriya, Anulom Vilom, the IOP was reduced, And in Bhastrika, Kapalbhati, there is a transient increase in IOP. Hence, the non-inverted poses and controlled breathing technique should be incorporated in management of glaucoma patients, and the inverted poses should be avoided, particularly in glaucoma patients. Thank you so much.
Everybody for this wonderful session and finished in time. Dr. Harsh just took 3 minutes more. Nice, sir. Picture, a group picture for the records, all the speakers and all the panelists and the judges and the chair people.